So that's what happens if a blood vessel basically goes kaput. It fills up. What happens if a blood vessel actually breaks? Well, this is called an aneurysm. Oops. An aneurysm. An aneurysm is when you burst a blood vessel. It usually happens at a weak point in an artery or potentially in the heart, where the connective tissue rips. You get a bulge that forms, and every heartbeat causes that bulge to split more and more and more and more and more. If it ruptures, you're going to die, probably. If you have a major aneurysm in your, in your heart or in a major artery, you can bleed out internally very, very quickly. If we detect an aneurysm that hasn't broken yet, we can go in and try to fix it surgically. If you burst a blood vessel, it's a smaller blood vessel, we might be able to go in and fix it before you die. If you burst a blood vessel in your brain, even a small blood vessel in your brain, that causes a stroke. There's basically two types of strokes. You can either have an infarction, where you have a clot or some embolus that blocks off a blood vessel in your brain, or you can have an aneurysm, where you actually have a blood vessel that bursts in your brain. The most common sites for aneurysms are in the abdominal aorta, the renal arteries, and the arterial circle at the base of the brain. If any of these things ruptures, you die. Probably. Before they rupture, they will often cause pain because you've got this bulging out that puts pressure on nearby areas. Most aneurysms result from either congenital weakness, meaning something that you're born with. Maybe it's genetic, more likely it's developmental, but it can also be due to arteriosclerosis, hypertension, trauma, or bacterial infection. Speaking of stroke, there are, like I said, basically two types of stroke, or at least stroke can be caused by either an embolus or by a burst blood vessel. There are two sort of types of stroke-like things. There's what's called a transient ischemic attack, or a TIA. These are sometimes called mini strokes or micro strokes. This is where you have basically an intermittent lapse of blood to the brain, but it's something that clears itself up fast enough that no permanent damage is done to the brain. So you have initial symptoms of a stroke, loss of cognitive function, headache, dizziness, nausea, loss of vision, weakness, paralysis, headache, aphasia. Aphasia is loss of basically the ability to speak or sometimes to understand words, and it can last for a few minutes to a few hours. The important thing with a TIA, a transient ischemic attack, is that it clears itself up. So it has few lasting effects. You haven't suffered permanent brain damage. Though this is usually a warning sign that there is something wrong. It's kind of like, I don't want to say the calm before the storm because it's not calm, but it's sort of like before you get an earthquake, you'll often get little tremors, or it's the smoke before the volcano. A stroke is like a transient ischemic attack. It's an interruption of blood flow to the brain, but it's one that does result in tissue necrosis and death. So you're losing part of your brain function. It's a sudden death of brain tissue caused by ischemia, which is basically interruption of blood flow to the brain. Your brain has a lot of redundant functions. So depending upon what part of the brain died and how much of it died, you may notice a lot of side effects. You may notice very few. Common effects of stroke are similar to the effects of TIAs, except they, last much longer. Blindness, paralysis, loss of sensation, loss of speech control, particularly paralysis in the face, loss of memory, loss of understanding of language or of shapes, or potentially nothing. Some parts of your brains are completely redundant. But if you have a true stroke, then you've had at least some level of brain damage. Recovery depends on the surrounding neurons and collateral circulation to the area. So you have to have some way to restore function to that part of your brain. All right, valvular insufficiency disorders. This is particularly in the heart. This is what happens when you have one of your valves that does not work properly. A valve should stop blood from flowing back where it came from, right? So your tricuspid valve stops blood flowing back into the right atria. Your bicuspid valve stops blood flowing back into the left atria. Your semilunar valves stops blood from flowing back into the ventricles. A valvular insufficiency is any time that the valve does not completely prevent flow, or what's called reflux or regurgitation. That's flow backwards. There are a few different types of valvular insufficiencies. There is valvular stenosis. This is where your valve cusps, right? So think cuspid, tricuspid, bicuspid. One of your cusps are stiffened by scar tissue, and they don't close properly. So even though they're like closing, there's still a little bit of an area that allows some blood to squeeze back through, right? That means that your heart isn't pumping as much blood as it should be pumping. So the heart has to pump harder to compensate for that. So the heart overworks. Like any muscle, when you work it, it gets bigger, the heart becomes enlarged. Well, there's a problem with that. When the heart becomes enlarged, just like with any muscle, it needs more blood flow. So if your heart becomes enlarged because you're not delivering enough blood, now it needs more blood, but you were already not delivering enough blood. So this starts the cycle to coronary artery disease and congestive heart failure. Valvular stenosis can result from lots of different things. Genetic factors, congenital factors, but often it's associated with rheumatic fever, which is a bacterial infection of the endocardial tissue, usually by strep bacteria, or autoimmune attack on the mitral and aortic valves. Since you have some blood that's like squirting back where it came from, it makes a sort of sound. I'm not doing it very well, but it's called a heart murmur, and it's very audible using a stethoscope. Mitral valve prolapse. This is particularly a disorder of the bicuspid or mitral valve, and this is where so the mitral valve should usually, right, go from being, sort of open to closed. And remember that this is braced by those papillary muscles that are like pulling it and keeping it from, well, prolapsing. Well, if you have a mitral valve prolapse, then instead you have your valves sort of bulge in, and your papillary muscles are insufficient to kind of keep them from bulging inwards, and in an extreme case, this can even cause the valves to sort of break free and open the wrong direction, allowing blood to flow backwards. This is occasionally a hereditary condition in about 1 out of 40 people. It can also result from a heart attack that damages the papillary muscles. Since it's happening in the left ventricle, right, that means that you have blood going back from your left ventricle into your left aorta, left atria, and so that means that you are not pumping as much blood as you should be pumping. This can lead to congestive heart failure, but it also means, remember that the first blood that comes off of the aorta, which is what this is feeding, goes to the heart itself. So that means that you're not giving sufficient blood to your heart. This can cause chest pain and shortness of breath. So, how do you detect valvular disorders? Usually you do so through what's called osculation, which is basically listening to the sounds made by the body. In this case, you're listening to the sounds made by the heart. You stick the little stethoscope on, and what you should hear is lub-dub. Sorry, it's lub-dub, 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 lub-dub. That's a normal, healthy heart sound. The first sound is louder and longer, and it's the lub-lub. The sound is actually not the beating of the heart. The sound is the closing of those valves. When the valves close and they shut, they make a noise like a slamming door. When the AV valves close, that's what makes the lub. When the semilunar valves close, that's what makes the dub. So remember that when the AV valves close, they close because the ventricles are contracting, and they're forcing a ton of high-pressure blood against them. That's why this is a louder sound, right? You've got, like, bigger doors that are closing to hold back a whole rushing ocean. When your semilunar valves close, they are stopping blood from draining back into the ventricles from the pulmonary artery and the aorta. They're not going against the whole force of your contracting heart, so they don't crash quite as large. They make a shorter sound. But S1, the first heart sound, happens first. Well, it happens basically at the end of atrial systole and the beginning of ventricular systole. The second heart sound happens at the end of ventricular systole, right after the ventricles contract and when they just start to relax. In children, you will sometimes hear a third heart sound, sort of like a lub-dub, lub-dub. This you don't usually hear in people over 30. All of this talk about valve openings and valve closings leads us to a discussion on the cardiac cycle. So the cardiac cycle is basically the mechanical events that happen in the heart, the order that they happen in, right? So one heartbeat from beginning to end. There are 4 main phases of the cardiac cycle. All right, so we're going to start basically right after the ventricles have contracted. Right, so the ventricles have contracted. They are beginning to diastole, and that means to expand. And so we are basically like right here. This first phase is ventricular filling. I know what you're thinking. You're thinking, oh, but don't the atria fill first? And yes, they do. But while the atria are filling, there's actually nothing to stop the blood from draining from the atria into the ventricle. So the atria fills, the atrioventricular valves are open. Some of that blood drains into the ventricles. There is basically 3 phases to this ventricular filling stage. It is actually the longest of the 4 stages. During the first stage, this is what's called rapid ventricular filling. This is when the ventricle is expanding. That creates suction that sucks blood in. So you have blood that moves into the atria and then just drains right into the ventricles. This is about the first third amount of time, the first third of the amount of time, and this is where actually, about half of the blood comes in. All right. Second, we have diastasis. All right. So during diastasis, this is in here. So you can see here is the rapid filling. Blood is rapidly draining into the ventricles as the ventricles expand. During diastasis, you have much slower filling. Diastasis basically ends with the P wave. Here you can see the P wave. If you'll recall, the P wave is atrial depolarization. Basically, by the end of diastasis, all of the blood that's going to drain from the atria into the ventricles on its own has drained. At that point, the atria depolarizes and the atria contract. This is the third phase, atrial systole, right? So by this point, the ventricle's already like 2/3 of the way full. And then when the atria contract, it squeezes that last third of blood, basically filling and overfilling the ventricles. So, even if the ventricles don't contract, you still get about 2/3 full of the ventricles. This is why you can actually live in atrial fibrillation for quite a while. Even if your atria don't function, your ventricles can fill most of the way on their own. That atrial systole, that final 1/3 you see here, this is where the atria contracts and it squeezes that final third of the blood in. That's just sort of to put the final like icing on the cake. And those are, that's the first step, right? Ventricular filling, which breaks down basically into 2 phases, well, 3 phases. But the first 2, the ventricle is filling on its own, and in the third, the ventricle is being filled by atrial systole. All right. In the next stage, this is what's called isovolumetric contraction, and it basically starts with the QRS complex, right? So remember that the QRS complex is atrial repolarization and ventricular depolarization. So the atria begins to unclench and the ventricles begin to clench. This is a very short phase. See here, so this whole section here, that was all ventricular filling. Just this little section down here, all right? That little bitty there is isovolumetric contractions. This is very, very quick. In isovolumetric contraction, basically what happens is you start off, the ventricles are starting to contract. The atrioventricular valves have not yet closed. It is the pressure increasing as the ventricles contract that forces the AV valve to close. So when the AV valve closes, you get the first heart sound, S1. Lump. You get the lump of lubdum. Lubdum. Alright? So that basically, isovolumetric contraction begins with the QRS wave and ends with the first heart sound, the closing of the AV valve. Alright? At this point, all of the valves in the heart are closed. The AV valves have closed, but the semilunar valves have not yet opened. In the next phase here, ventricular ejection, that's from here to here, right? In this phase, as the ventricles contract, you can see pressure increases. Ventricles contract, pressure increases. That pressure can't go out the AV valves if they're functioning properly. So instead, it opens up the semilunar valves, forcing blood out of the pulmonary artery or the aorta, depending upon whether you're talking about left or right. So pressure rises, semilunar valve opens, blood is quickly ejected at first. So if we look here, this is the blood volume in the ventricle. We can see that it rapidly decreases and then sort of slower at the end. Like anything, it's easier to squeeze something when it's full. Getting out the last dregs are kind of difficult. As we'll see in a second, you actually never completely empty the ventricles. So at this point, in ventricular ejection, you are ejecting the blood out of the aorta, the pulmonary artery. The semilunar valves have opened, and this ventricular ejection ends with the T wave. Remember, the T wave is ventricular repolarization. So this is when the ventricles are done contracting and they have just started to relax. Right? As soon as the ventricles begin to relax, pressure begins to go down in the ventricles and the blood begins to rush back in from the aorta and the pulmonary trunk. Right? That blood starting to come back in is what causes the semilunar valves to close. In isovolumetric relaxation, the ventricles begin to relax. Blood would like to rush back in. The semilunar valves close to prevent that blood from rushing back in. And when those semilunar valves close, that's what causes the second heart sound, dup, to occur. So this is the dup of lubdum, lubdum. And you can see here This is that isovolumetric relaxation right here, and that is where the S2 heart sound is. And that is the cardiac cycle. Right after that, you begin with ventricular filling again. So here, this is the dup sound here, and then you immediately begin ventricular filling again. You have your rapid ventricular filling during diastole, and then you have atrial contraction that squeezes the last bit in. Those are the events of the cardiac cycle. Like I said, you never actually empty the ventricles of fluid, right? It would actually be very dangerous to empty the ventricles of fluid because it would be like if you've ever seen like two plastic bits that get wet and then they touch each other, they stick to each other, right? So if your ventricle ever got actually empty, it would actually be hard to get blood back in. It's the fact that there's some space there to expand that allows it to expand easily. The amount of blood that is left in the ventricle after blood ejection is what's called the end-systolic volume, right? The volume of blood after systole, and that is about 60 milliliters of blood for a normal resting heartbeat. When blood is being passively added to the ventricle, that's before the atria contracts, that is basically 30 milliliters. When the atria contract, it adds about 40 more milliliters for a total end-diastolic volume, the max volume of the heart, of about 130 milliliters. All right? If the end stroke volume is 60 milliliters, then that's, once the ventricles contract, we're going to go back down to 60. And so that means that we're going to eject about 70 milliliters from the ventricle, and that is what is called our stroke volume. Now, this can change depending upon blood pressure, whether you're male or female, heart pathological conditions, and whether or not you're undergoing exercise. Now, this is a good sort of at-rest average here. Note that I've just been saying end-diastolic or end-systolic. I haven't been saying whether it's the right or the left ventricle. There's a very good reason for that. If your body is working properly, then the stroke volume of the right ventricle must equal the stroke volume of the left ventricle. Both ventricles have to eject the same amount of blood. If you don't do that, then you end up with a pathological condition. One possibility is congestive heart failure. With congestive heart failure, that basically means that usually that is what's called a left ventricular insufficiency. So you're pumping more blood out of the right ventricle than you are to the left. Well, that means that blood backs up in the pulmonary circuit. That you have an increase of blood pressure because you're pumping more blood into the pulmonary circuit than you're getting blood out of it. Think of what happens on a highway if you've got more cars going onto a highway than come off of the highway. It gets congested. That causes blood pressure to go up, which forces fluid out and into the lungs. As the lungs fill with fluid, oxygen exchange becomes more difficult. You have less oxygen getting into the blood, which means you're going to make more blood cells, and you're going to increase your blood pressure, both of which are going to cause the lungs to fill with blood even faster, leading to a positive feedback loop, albeit a slow one. This is a slippery slope. Once you start to go into congestive heart failure, it generally progresses unless some sort of action is taken. So here you can see on the left, this is a congestive heart failure system. Right ventricular output is exceeding left ventricular output. So you have more blood going into the lungs than you have blood coming out of the lungs. That increases pressure inside the lungs, resulting in the lungs filling up with fluid. If you have right ventricular insufficiency, you have more blood going out of the left ventricle and into the system than you have blood returning and going into the pulmonary tract. That causes a similar problem except in the systemic circuit. Systemic circuit's much larger than the pulmonary circuit, so it's going to take longer for effects to be felt. But this will result in systemic edema, as well as increased urine volume, and potentially hypertension and thrombosis. If you don't have blood returning fast enough, that means it's staying stagnant, and there's more opportunity for thrombosis to take place. All right, since we're talking about fluid leaving the blood vessel, either into the lungs or into the tissue, I want to talk a little bit about how that process happens. All right? This is blood filtration and reabsorption, and this is happening constantly in your blood cells, or in your blood vessels, all the time. In any blood vessel, all right, let's draw a blood vessel here, and you've got blood inside. You have pressure that is being exerted by the blood on the blood vessel wall. So you have fluid that is being forced out. This fluid should be mostly water, ions, and small molecules. Right? It tends to come out of fenestrated or sinusoid capillaries. Those are the ones that are most leaky. And it should, if your arteries and capillaries are functioning properly, should not contain blood cells or large proteins. So you have blood or fluid from your blood that is constantly being filtered into the surrounding fluid. Well, if that was the only thing that happened, you would be losing blood all the time, or losing fluid all the time, and your blood volume would be constantly going down. So actually your blood vessels also reabsorb fluid from the surrounding tissue. You know, which is it, right? Is fluid going out or is fluid coming in? The answer is it's both. Depends on where you look, depends on when you look. There are two important forces here, and pay attention to them because they're going to come up again when we talk about the kidneys. The two opposed forces are blood hydrostatic pressure. This is blood pressure. This is exactly what you think of when you think of blood pressure, right? It is the pressure exerted by the blood fluid on the blood vessel wall. The more fluid you exert on the wall, the more fluid you squeeze out, like squeezing a sponge. Higher blood pressure means more fluid is filtered out. Now you think about where this is going to happen. Where is blood pressure highest? Blood pressure is higher in arteries and lower in veins. Generally speaking, this filtration is happening in the capillaries, not in major arteries or anything like that. It's happening in the capillaries. So the artery end of the capillary is where you're going to have more blood pressure, and therefore more blood fluid leaving the capillary, being filtered. The force that draws blood back in, or fluid back in, is osmotic pressure. Remember when we talked about osmosis? Water goes to the place where there's less water, right? So you've just squeezed a bunch of water out of the blood. Now there's less water, more protein, more cells. This produces an osmotic pressure. There's a diffusion gradient. You've got more water out here, less water in here. Water wants to diffuse back in after having been squeezed out. This osmotic pressure is called colloid osmotic pressure, or COP, and it results from mostly plasma proteins, blood cells. Now, it's not just the osmotic pressure, because remember, what matters is a concentration gradient. So the net pressure that's felt drawing fluids back in is what's called the oncotic pressure, which is the blood osmotic pressure minus the tissue osmotic pressure. If the osmotic pressure in the blood, if there's more stuff, less water in the blood, and there's more water, less stuff in the fluid, then there's an osmotic pressure for water to diffuse back in. In general, about 85% of the water, of the fluid, I should say, that is filtered out of the blood in the capillaries is reabsorbed. What happens to the other 15%? It gets collected by lymphatic ducts, which are small ducts that usually run parallel to capillaries and blood vessels. They collect this squeezed out fluid, which is now called lymph, and which may contain white blood cells that can escape from the capillary. And eventually this lymph fluid collects in the lymph ducts, gets filtered through lymph nodes, and it eventually gets added back into the blood. There's a few collection points we'll talk about later on, where this lymphatic fluid basically gets dumped back into the blood, restoring that balance. Here you can see a nifty little picture of that happening. Now, on the arterial end of this capillary, you have higher blood pressure and lower COP, right? The COP doesn't actually change all that much under most circumstances, but the blood pressure definitely does. So here we have a blood pressure of 33 out and of 20 in. So we're going to be forcing fluid, remember it's fluid, not blood cells or proteins, out of the capillary. By the time you get to the venous side of this capillary, blood pressure is much lower. Now it's only 13 out and 20 in. So now the net reabsorption pressure goes the other direction, and we have fluid flowing in to the venous end of the capillary and then into our venule. All of this is in service of talking about a few pathologies here, specifically edema. Edema is what happens when you have excess fluid leaving the capillaries and less fluid being reabsorbed. When there is an imbalance, right? So your lymphatic system can handle a little bit of an imbalance. You usually filter a little bit more than you reabsorb, and that fluid gets collected by the lymphatic system, and it just gets channeled back in. But your lymphatic system has basically a maximum capacity. If instead of there being a 15% difference, if you only reabsorb 50% of what you filter, all the rest of that fluid has to go somewhere. Lymphatic ducts can't carry them all. And so what happens to that fluid? Well, it collects in the tissues. This is edema. Whenever you have a hydrostatic imbalance and you force fluid out of the blood and into the tissues. There are three primary causes of edema. You could have increased capillary filtration. This can be caused by a few different things, but usually they're going to all basically result in high blood pressure, right? You could have kidney failure. That means that you're not excreting enough fluid usually, and you're not excreting enough toxins. That means that your blood volume goes up, your blood pressure goes up, you squeeze out more fluid into the tissues. Could be histamine release. Histamine actually causes your capillaries to become more porous. Histamine is involved in the inflammatory response, and it's why when you become inflamed because of an injury or an infection, your skin becomes puffy. That causes more blood to flow to the area and more fluid to get squeezed out, because that fluid that gets squeezed out contains white blood cells, it contains proteins that will help you fight off infection, it contains antibodies, things like that. Old age, generally speaking, old age makes everything worse. And poor venous return. If you have poor venous return, then particularly in your legs, you have basically a buildup of blood in the veins that creates more blood pressure. That blood pressure then forces more fluid out into the tissues, right? So that's increased. You have more stuff going out, right? Or you could have less stuff coming back in, right? A deficiency in your reabsorption. What could cause this? Well, hypoproteinemia. If you do not make enough blood proteins, then you decrease the amount of osmotic pressure there is pulling water back in. Liver disease. Liver disease can result in hyperproteinemia. Remember that most of those proteins found in your blood are made in the liver, and again, a dietary protein deficiency. If you lack protein in your diet, you're going to have a hard time making proteins to go into your blood. So basically, all of these go down to hypoproteinemia of some sort or another. Last cause of edema is a lymphatic obstruction. Remember that 15% that we said about? Well, that 15% gets dumped back into the blood later on. But there's a whole network of lymphatic vessels. If those lymphatic vessels get plugged, then they no longer work. And that 15% that's usually absorbed by the lymphatic system and then channeled back into the blood later on just stays in the tissue. And it builds up over time. It's 15% now, but it's a 15% that's constantly not being dumped back into the blood, and it builds up. So surgical removal of the lymph nodes or cancer in a lymph node, anything like that can cause lymphatic edema. What are the bad things about edema? Well, too much fluid can actually kill cells. You can cause the cells to, basically the tissue to become so inflamed, there's so much pressure there that you can cause tissue death. You can put pressure on nearby arteries that would retard oxygen delivery. You're not taking wastes away, because one of the reasons why this whole exchange of fluid being filtered out and then absorbed back in takes place is that flow, when those fluids go out and then come back in, they carry out sugar, usually, and ions and other things, and they carry waste products back in. Well, if you're not carrying those waste products back in, then they build up and they can kill the tissue. If edema takes place in the lungs, then that is pulmonary edema, which basically is the same thing as congestive heart failure. Your lungs begin to fill up with fluid. That means you have less oxygen taking place, less oxygen exchange taking place, which means that your heart has to work harder, increasing your blood pressure, increasing the amount of edema. Eventually, this can lead to suffocation. You can drown in the fluid in your own lungs. Cerebral edema. This is a buildup of fluid in the head or in the cerebrospinal fluid. Can cause, on the less severe end, headaches and nausea due to increased pressure put on the brain. It can also cause seizures and eventually coma, potentially death. If you have edema due to, for instance, increased permeability of the capillaries, so perhaps due to histamine release, or due to some sort of toxin or breakdown of the capillaries, then it's entirely possible that you have so much fluid, leaving your blood and into the tissues that it begins to have an effect on your blood volume, lowering your blood pressure and potentially causing shock. This is what's called circulatory shock. What is circulatory shock? Well, anytime you've heard shock in a medical sense, that's probably we're talking about circulatory shock, right? The formal definition is any time that cardiac output is insufficient to meet the body's needs. This is typically felt in the brain first, because that's where you need blood pressure to get blood up to, and the brain's pretty important, right? The heart is usually perfusing itself pretty well. If it doesn't, you end up with a myocardial infarction and what's called cardiogenic shock. I'll talk about that in just a second. But typically, lack of blood pressure is going to be felt in the brain first. There are two basic types of shock. So what's called cardiogenic shock and low venous return. Cardiogenic shock is effectively what happens when you have a heart attack. When your heart stops pumping, or when your heart's pumping efficiency goes down. When it stops pumping enough blood. Typically, cardiogenic shock is a result of myocardial infarction or potentially atrial or ventricular fibrillation. But it's some problem with either heart muscle dying or losing conductivity or sinking of the muscles of the heart. If your heart doesn't pump, you go into shock because you can't get blood up to your brain, or to the rest of your heart, or to the rest of your body. It's generally a bad situation. Low venous return is when you have shock due to basically inadequate blood going into the heart. Typically, this is caused by low blood pressure. There are three principal forms of low venous return shock. There's hypovolemic shock. Basically, that means that you don't have enough blood returning to the heart because you don't have enough blood. You've lost blood volume, possibly due to trauma, right? Somebody put a big gash in you and you've been bleeding out. You're now down 2 or 3 liters of blood and you don't have enough blood pressure to get blood into the heart. Could be through burns. Burns lose fluid really, really fast. And when your body loses fluid, ultimately that fluid comes from your blood. Or dehydration from any other means. Right? So that's basically traumatic shock, right? Loss of blood volume. You could have obstructed venous return shock. This is pretty rare. This is when you have something, a tumor or an aneurysm, that basically shuts off a vein, compresses a vein, a main vein, preventing that blood from returning to the heart. That's obstructed venous return shock. Or you can have vascular shock or venous pooling shock. This is shock that is due to basically potentially long periods of standing or sitting, or more commonly, widespread vasodilation. If you have widespread vasodilation, then you don't have enough pressure to push blood back to the heart, and so the heart can't get that blood up to the brain. There are several different types of venous pooling or vascular shock. Sometimes they're combined with a few other types of shocks as well. One common type is what's called neurogenic shock. This is loss of vasomotor tone, so vasodilation that's caused by the brain. Often it's caused by emotional stress or shock, right? So this is like something scares you and you pass out, right? That's because your brain basically sends a vasodilation signal to your body, your blood pressure drops dramatically, and you pass out. It can also be caused by brainstem injury. Remember, your brainstem regulates blood pressure. If you injure your brainstem, it does not properly regulate your blood pressure. Septic and anaphylactic shock basically have elements of both vascular shock and hypovolemic shock together. Both of them work by sort of similar mechanisms. Septic shock is triggered by bacterial toxins. Anaphylactic shock is triggered by your body's own immune response, often an allergic response. But the result of both of them is basically the same, right? You trigger system-wide vasodilation, resulting in vascular shock and a huge drop in blood pressure. You also trigger an increase in capillary permeability. Remember, we said that histamine release is part of the inflammation system. Well, it's triggered by the immune system, and it can be triggered by bacterial toxins. In fact, sometimes the way that these bacterial toxins work is by triggering the anaphylactic system. And so you not only have massive vasodilation, but you also have a huge increase in the permeability of your capillaries, causing causing fluid to leave your blood to the tissues. So you have not only systemic vasodilation, but also systemic edema. That means that you have less blood volume as well as less blood pressure, combining both of these together. That is a potentially deadly combo. Last thing that I want to talk to you about is probably the most common cardiovascular pathology, certainly in America, possibly worldwide. That's hypertension. Hypertension is a fancy word for high blood pressure. This is the most common cardiovascular disease in America, affecting about 30% of Americans over 50. It's sometimes called the silent killer. You don't feel it. Low blood pressure you feel. Well, low blood pressure, for long enough, you stop feeling anything. Low blood pressure kills quick. And if it doesn't kill quick, you pass out and then blood gets back to your brain some other way. High blood pressure, you can't even feel it. Your body's got mechanisms for dealing with it. But over time, it builds up. It's a major risk factor in heart failure, stroke, and kidney failure. Right? Increasing blood pressure increases the amount of stress that you put on arteries. That can cause increased afterload in the heart. That means that your heart isn't getting rid of all of the blood that it should be, and over time it gets more and more and more full. That causes the myocardium of the ventricles to get overstretched. When they get overstretched, they grow, just like any muscle does when it's stretched. When it grows, its oxygen demands increase. And that increases the likelihood of heart attack. Anytime you increase oxygen demand of the heart, you increase the likelihood of myocardial infarction. In addition, you're putting stress on the arteries. That causes micro tears in them. These are places where atherosclerotic plaques can form. Kidney failure, increased blood pressure causes your kidneys to filter more fluid out, which means they basically have to work overtime getting all of that fluid back in, which we'll talk about more when we talk about the kidneys, but most of the blood that's filtered out of your kidneys is returned to your body. And in response to that, your renal arterioles thicken, and you have a drop in renal blood pressure, which leads to salt retention, right? So salt retention increases blood pressure more, and so you end up with a positive feedback loop. There's sort of a theme here. Most of the time, positive feedback loops are pathological. There's a few circumstances in which they're really important, your body has to have them. Most positive feedback loops are anti-homeostatic. Hypertension can be either primary or secondary. Primary means that it's basically the main thing that's wrong with you. Secondary hypertension means that your hypertension is caused by an underlying condition. Primary hypertension is usually, it's 90% of all cases, is the most common, often caused by obesity. Obesity means you just basically have more square miles of capillaries to push blood through, and that takes more force to do. So you have to have a higher blood pressure. Sedentary behavior, which contributes to obesity, but which also contributes to weakness of the heart. And as we see up here, that means that your heart enlarges and becomes weaker and less efficient. Diet, particularly salt, cholesterol, things like that, and nicotine and any other stimulant. Nicotine is a very, very potent vasoconstrictor. So it raises your blood pressure really, really high. Caffeine, to a lesser extent, does. But any sort of stimulant drug is going to have a similar effect here. Secondary hypertension is hypertension that's caused by some other problem, right? Kidney disease. If you are not excreting the amount of urine that you should be excreting, that causes blood volume to rise, causing hypertension. Atherosclerosis. If your blood vessels do not stretch properly, then you can't control their diameter properly, and that can lead to high blood pressure. Hyperthyroidism causes, a number of different problems, but increased metabolism, muscles working harder, heart working harder, everything like that. Cushing syndrome, increased adrenocorticosteroid production, leads to basically higher stress, higher release and activation of the sympathetic nervous system, things like that. There's only about 10% of cases, but here you have to treat the underlying syndrome, not the hypertension directly. All right, I know that was a really, really long presentation. I may be breaking this up into 2 parts, in which case you'll know about it because you're already at the end of the second part. But thank you all for listening, and study good for the next test. Bye.